Today, I'm joined by Sam Smith, founder and CEO of Amissa. Sam is building in women's health with a focus on improving how menopause care actually works in the clinical setting. Instead of adding more noise or more burden to already busy providers, Amissa is focused on helping clinicians move from fragmented symptoms and scattered patient input to clear, more useful, visit ready context that supports better care decisions. In this conversation, we'll talk about what breaks down in menopause care today, why symptom complexity can create overload for both patients and clinicians, what visit ready information should actually look like, and where wearables and tracking help versus where they can add confusion. So, the goal here is the pattern in the lesson, not anything sensitive. Sam, welcome.
Thank you for having me. You should do all my intros and pitches just because it makes it way easier for me to come in and just do the easy part.
Get going. All right. Okay. So for listeners meeting you for the first time, what's the simplest way to describe what you're building at Amisa and who's it for?
Yep. So menopause care is complex. There are over 40 symptoms involved with menopause. Simply put, what we're doing is we are assisting clinicians in organizing that patient symptom data, which is necessary to provide care. But by relieving that fragmentation of data, we also have effects that are beneficial to time spent in charting, ROI when it comes to reimbursement and properly documenting exactly what's going on with each of those patients, and overarchingly helping every core player that menopause touches. Of course, you think the patient, number one, making sure they get better faster is the ultimate goal. But by supporting the clinician in doing so, it has a lot of downstream effects.
Okay. What do most people misunderstand about menopause care, either clinically or operationally?
I think there's two clear misses. One's historical, and one is an opportunity that's being clearly seen now by health systems as well as individual clinicians who might want to break into their own private practices. One is that menopause is something that you have to just suffer through, that it's a normal thing. I think it's a very female experience that there are moments in our lives that you are just expected, whether it's pregnancy or menopause, like that's just what it is. Like you got to kind of just suck it up and suffer. But data shows that making sure that you take the appropriate care during these time periods can help with lifespan, your day to day well being. I mean, overall, you shouldn't, as a woman, be told that you have to suffer or that your symptoms are not worthwhile. And it's really the moment that we are in as far as like the benefits of timing as a startup is that the awareness around menopause is there's definitely an inflection occurring right now where women on social media are recognizing that they don't have to deal with this anymore. That is a revenue generating opportunity for enterprise health systems. You again assume that making people feel better is number one goal, right? And we go, let's say that both things can be true at once. But if you think about the number of women who are going to their OBGYNs, which only 7% of OBGYNs even feel sufficiently trained in menopause care to even support
Hmm.
their patients. Think about the money that's left on the table as far as retention of those patients, or how much money is being spent from a payer perspective for the number of visits that women are going to try to get a menopause diagnosis. There's a range of data around this, but roughly 19% of women are even diagnosed with menopause, even though all of us females are going to go through it. So if you
Wow.
imagine that 80% of women suffer from menopausal symptoms, suffering meaning it's affecting your work, it's affecting your mental health, your relationships, true, really day to day questions around what's going on with me. Think about how much expense. Well, I don't have to think about it. I know the number. It's $25 billion the Mayo Clinic has assigned to the issue of not being able to properly diagnose and care for menopausal patients.
Oh, that's amazing. Oh my gosh. So, in a typical appointment today, where does menopause care break down most often?
Holistic, which is frustrating. But really, where we step in as a company, we have been called the plumbing of menopause care. It's
It is.
not, yeah, I know. I'm like, I'm really, with all of the things I try to accomplish in life. But the core thing to note is that these data exists. It's just fragmented. This is data that's being requested. It's just hard to gather. And that's because menopause, whether it's why are only 7% of OBs, why do they feel sufficiently trained in doing this? It's because there's no menopausal education that's part of the curriculum for them to need to actually learn it to do their job as OBs, which is kind of upsetting. If you're a woman, you'd think that that's the number one person who you'd be able to go to. But think about that when it comes to your EHR or your electronic health record. Those systems did not consider menopause either. So the entire infrastructure was not set up to support the workflows necessary to really treat menopausal patients and support the clinicians treating those patients. Now, the way that we step in and what we're trying to accomplish is how can we tie these different pieces of data, whether it's a validated assessment that is part of intake or pre-appointment, symptom tracking, which is necessary and recommended by clinicians, or wearable data that patients are trying to shove in your face. Three pillars of data. How do we create it into one clear view that's usable by every party that we're talking about?
Okay, so you've used the phrase visit ready information in plain language. What does that mean?
And I really like this question because I think what it highlights when I think about the shoes I'm stepping in for the clinicians is twofold. One is that you're dealing with a population of women. Imagine OBs aren't educated. We as women are also not educated in what it means to go through menopause, specifically perimenopause. And that's a word that's becoming more mainstream, but it's the years before menopause takes place. Again, menopause is just that moment that you've officially gone a year without having your period. That is menopause. Everything else is peri, pre, and post menopause, a 10-year journey. Clinicians have roughly 15 minutes to not only educate their patients on what menopause is, but then extract the information as far as what symptoms are occurring in your life. And if you're anything like a normal human, you're usually thinking about the last few days. You're like, oh, well, I had a headache yesterday and I guess I didn't get much sleep. Well, maybe that was my daughter waking me up. I don't know. When really what you need to understand what is the best course of treatment is what has been happening to that woman over the last 30 days, over that cycle if she still has it, but at different inflection points to better understand which direction you should go. Being able to capture that information, let's say if the average wait time I'm seeing for a patient to get into an appointment is roughly 3 to 6 months, which is
Jeez.
nuts. And if you think about the opportunity as far as a health system, the patients who are leaving to find care more quickly, which makes complete sense to me, is an issue. What you can do in the meantime to support that clinician and that patient and keep them engaged is start tracking symptoms. So when they come in to the room, not only are they educated on what the symptoms are, because we've presented it to them, but we also have an understanding of what symptoms they're suffering from and when, which is what's most important in providing care.
So ideally, the clinician again has what when they start off, when the visit first starts?
Yeah, the view that we present to them, we actually present them with the PDF of the
Oh,
symptoms that's pushed into their EHR. Again,
okay.
fitting within their workflows. It's just a clear overview. There's two different versions. One is the menopause rating scale. It just shows on an 11 questionnaire assessment how severe are your symptoms. And the higher the scale, the more severe. The next is a more detailed version of symptom tracking. It just shows your over 30 days exactly what is going on when it comes to symptoms and severity, as well as you can see if your wearables are attached, how you've been sleeping, your activity, and your heart rate, which you can learn a lot about a woman from the heart rate. So that's what the clinician is able to see, quickly assessing and understanding information that you probably would have not have been able to actually pull out from questions in that 15-minute time period.
What's the difference between helpful patient context and just more data that creates noise?
That's a good question because I think when we interviewed over 100 researchers, clinicians, and patients when we were creating Amissa and what exactly we wanted the output to deliver. And one thing that we heard was, please don't hand me more unnecessary data. I'm not going to use it. It's annoying. This is the clinician voice.
Yeah.
Whereas if you have the opposite from the patient, where if they're wearing wearables every day and they're very attentive to ensuring that they're tracking their sleep, their activities, and they feel like they're gathering relevant insights to help guide what could potentially be wrong with them. You have two conflicting feelings around data. The ability to organize data in a way that's usable from the clinician standpoint and representative of the person that they're trying to treat, in this case, a midlife woman. That's really where things go wrong. And being inconsistent from different data sources on how this is presented, whether it's a wearable data source or an assessment, and you're dealing with clinicians who, I mean, people in general, if you haven't dealt with something, I'm not going to learn how to do it and then learn it in different ways, make it easy for me, make it palatable, and I'll leverage it. That's really what we're accomplishing by creating one view that makes these pieces of data more relevant to what they're trying to accomplish.
And apologies if you already answered this, but what should be surfaced before the visit in minutes?
Yeah. I mean, what should be surfaced? As far as when it comes to talking to patients, I would say the pain point right now when you're thinking about the clinician's job, and let's say they have 29 patients in a row who all of them could have 3 to 5 symptoms they're suffering from the 40. The issue is figuring out the right words to extract that information, which should be unnecessary and is unnecessary when you have the proper workflows in place supported by us. So that information is surfaced at the beginning rather than making the clinician play Sherlock Holmes for 10 minutes.
Nice.
And if you're anything, and I'm not, there's some uniquely female experiences that if you've been to 4 appointments with people telling you, you just kind of got to suffer through it. This is normal. This is what your experience it is. Like, I don't know what you want me to do. The frustration that comes from being told that over and over and over again, you come into these appointments pretty volatile and pretty upset. The one thing that's really that we've heard from our patients over and over again is simply being able to see the clinicians see the symptoms and start acting on them is validation. I'm not
Yeah,
wasting
that's
my
great.
time. Yeah, which is a funny, like, not funny, but kind of sad, just way of being where they basically have been told by, we all respect doctors. We think they're the smartest. If that person tells us we're crazy and like this is just kind of what life is, that's a pretty tough pill to try to swallow. And
Mm.
obviously, my hope is that if women ever experience that, they find a different doctor. But that validation right off the bat sets the tone for a better and more productive conversation.
So, if you were giving patients or a practical guide, what's worth tracking and what tends to create more confusion than clarity?
That's a good question because what's funny, one random piece of insight that we get from our clinicians who are actively using it is that even when patients, if you're starting with the ones who are starting to track the trends, even when they're getting better, some patients don't even recognize it because the symptoms that are important to me are maybe not actually the symptoms I'm suffering from the most, which might sound crazy, but I'll give you like a really clear, basic example. Maybe my weight gain is the thing that is like what bothers me the most. And but at the same time, I haven't been sleeping well. I've had hot flashes every day. My anxiety is nuts. Um, all of that starts to easily resolve. But then I get to my 6 week later appointment, and I'm like, this weight has not changed. You have not helped me. If that's what's most important to me, then it's hard to see everything else, the forest beyond the trees, if you will. When you ask like, what's noise? There's some things that bother us individually, right? That it's more of like a mental health exercise of what are you actually suffering from versus what are your personal preferences. As far as from a clinician perspective, we want to hear sleep is your anxiety, depression. Those are your core, especially with perimenopause that people don't relate with perimenopause. Those are the core symptoms that you need to ensure are okay for your day-to-day well-being, and the people around you, your work life, etc. It's also the mental model, and we can get deeper into this about like talking about libido and how to be able to decipher or discern that from maybe you're just not interested in your partner at all and your libido is perfectly fine. Like there are ways to test this, by the way, that I've talked about with clinicians, but a lot of this is your focus is, oh, my relationship sucks. It's not getting better because you're not sexually active. And it might not be about your libido. It could be your anxiety. Like there's a plenty of like ways that you can start to slip into what's important to me as a patient, which what is noise to your clinician. My tip would just be like evaluate what you're actually suffering from and prioritize it, which is what our app enables.
And then, where do wearables and symptom tracking generally help in a clinical conversation? And where can they mislead or overwhelm?
Yeah, I think that's another good question because there's a lot of varying opinions on wearables' place, for a lack of a better word, in the healthcare system. A few things to note that there are only a few areas in which wearables are actually FDA approved to report data to clinicians. So, our stance as an organization is that wearable data should be viewed as insights or signals that can help you potentially go into a deeper direction and make it easier for the patient to passively hand you information without you trying to pull it out. Sleep being a core example of this. But, as far as, like, depending upon the clinician and how they wanna leverage it, again, your heart rate, temperature is important for fertility. There's certain areas that we wouldn't be able to track otherwise, and you're also asking women to symptom track. Again, a necessity, and data shows 42% of women, once they start symptom tracking, they start feeling better just after 2 weeks, just from symptom tracking. Again, maybe part of that is the validation, but it's another task that you're asking women to do on top of all of the tasks that they're doing. They're potentially watching children or their elderly parents, they're working, they're organizing their households. Please, let's add another
Like,
task to
yeah,
their list.
what's going on?
So the idea of being able to take the potentially wearable data and creating digital biomarkers on top of it that can collect these moments. For
Mm,
example, can we collect when a hot flash happens so you don't have to report it? Can we leverage your anxiety data or your heart rate to better predict or showcase how anxious you're feeling and at what frequency? There are plenty of pieces of data that exist once you connect to wearable that we can generate insights passively that you can feed your doctor. So we stop asking women to continually self solve all of these problems. And
yeah.
for us, we've been operating with over a dozen clinicians now. We have over 25 million data points at this point. Just think of what we might be able to accomplish in a very underserved and under researched environment to support not only these women's, but also the researchers who are trying to better understand how can we identify early, some women who are at risk when, by the time they get to 55 or post menopause, osteoporosis has already gotten to a point of high concern. Cardiovascular disease has increased. There's plenty of indicators that we might be able to catch earlier on to help with preventative medicine.
Whew. So from the clinician side, what does a better workflow actually change in the room?
Yeah, I think one of the things we don't think about with clinicians is once they leave the room too. So in the room, we've talked about that a bit as far as validation, easier documentation, etc. A lot of menopausal or midwife clinicians, OBs, PCPs, are exhausted because of how much information they have to wrangle, charting, etc. We call it pajama time. How much time are they spending out of the office completing charts to make sure that they're documenting correctly and appropriately to ensure that it reflects the symptoms and is charged appropriately and not leaving money on the table? This is a lot of time. It's extra stress. It's a lot of emotions. It's a lot on top of a lot and that you're asking these clinicians to do to go above and beyond to ensure that this woman is getting the treatment that she needs and it's being coded appropriately. What our service does as far as in the workflows by accurately documenting these symptoms off the bat and enabling that provider to interpret it, we're providing clinical decision making support that could potentially increase how much money they're making by just upcoding to the appropriate code because now the documentation can support it. And I
Mm.
can get into reimbursement if you want, the sexiest topic of all, but it is ROI. Imagine the difference of $50 per patient simply by leveraging a document where we've collected and organized it all for you. You don't have to spend the time justifying it, it's there. Just put what you did as far as a suggested advice for that patient or a next step, and you're good to go. That's a savings of time of around 10 minutes per patient, which again, if we say we fit 29 patients into a day, just imagine what the health system is thinking as far as not only generating revenue, but also retention when it comes to these clinicians who are burnt out. So helping from multiple arenas simply by organizing the data.
That's massive. What surprised you most once you started building this in reality of clinical practice?
I think what surprised me most is, especially as we were just trying to discover our ICP or our ideal customer profile, it was really clear that we wanted to focus on menopause specialists. That might be obvious to everyone, but what does that mean? Because you have cash pay, private practice, entrepreneurs who spun off of these hospital systems and have started their own practice because they saw a wide open opportunity, which is smart. But then you have and they have 60 minutes that they usually bake in because they have discerned from their experience that's how much time you need to actually have a conversation and make women feel heard and validated and to treat them appropriately. Then you think of the clinician who only has 15 minutes. the pain that each of them are experiencing and the wishes and the wants that they want from technology are identical. So when you think about the environments you're in, the pains, no matter if you are the largest hospital system and have all of the money at your back, right? And you'd assume all the tooling or support staff, the pain is still the same because these systems haven't been set up to support either. So I think that was a huge learning. But even taking a step further, when we're talking to hospital systems, they're asking us about how their oncologists can use this because women who are in chemo or radiation are thrown into menopause or bone health or cardiology. Menopause is not bikini medicine. It affects every part of your body, which is why there are so many symptoms. So, one of the questions we get from these larger institutions is how, if the knowledge base from our OBs, the people who are supposed to be good at this, is so limited, how can we democratize knowledge across anyone dealing with a midlife woman to solve for that issue I mentioned at the top, which is misdiagnosis? That is, if you think about AI and the potential of where we can go with the data points that we're collecting, the position we're putting ourselves in, that's the future. If you're dealing with a midlife woman, they should be able to, hopefully in the 10 years from now, we can collect almost every symptom simply by the wearable and make it passive. How can we better instruct these clinicians, no matter what their specialty is, to service that person?
Okay. So, for operators building in health tech, what have you learned about designing for the way care actually happens rather than the way you wish it happened?
Yeah, I think the core learnings, and I think you and I discussed this before, that my innovation, once you get past all the wearables and the data, is actually a PDF and fax, like the sexiest innovation known to startups since Anthropic. But the real focus here was how can we, and this is being repeated back to me from every almost enterprise or health system environment, how can we integrate into their workflows without directly integrating into their EHR so that
Yeah.
we can make it low lift, prove ROI and value, and showcase it to a broader group without the pain? Exactly what we can accomplish, feeding into the narrative that, yes, eventually we would love to directly integrate, but how can we create workflows around those constraints? I would say that the interesting thing about healthcare is that fax is still there. That was a learning. We were talking to all the EHRs trying to figure out how we were going to push and pull data. And I had an advisor who was like, "Have you ever thought about just faxing it?" And that just came up on the Pit last week. I don't know if you watch the Pit, but they went when a cyber attack happened. They went old school and were faxing information back and forth. And I was like, "I'm ahead of the curve. I'm on fax." But the delay in technology and innovation in this environment is beneficial in that sense, but also in the sense that when you have investors come to you or people come to you and they're like, "Oh, well, why couldn't an EHR do this?" I'm like, yeah, why haven't they done it? That's a really great question. We can lay out the rationale as to why corporate environments are slow and don't feel the necessity of being pushed into specific directions because they're a monopoly. Like we can go into that conversation, but it's ripe for opportunity if you think about it from the perspective of a startup like us. And if you can operate outside of an EHR, now my clinicians who are working with us, we probably have 15 different EHRs that we're working from. Again, you think Epic, and then below that, you think Athena, because they focus pretty heavily on OBGYNs. But these cash pay practices, they're asking us to be the EHR because nothing, like I mentioned, nothing is working the way they need it to for menopausal care. So, and I'm not saying we're going to build our own EHR. I want to be clear. I'm just saying we're being asked,
Yes.
but it presents the opportunity and a clear product understanding through conversations that really only became clearer when we brought advisors in from a enterprise environment as well as from a cash pay concierge environment to sit down and talk through how do your workflows work now, how do you wish they work, and what's possible. That potentially simple, hacky ways of doing it are enough.
So, looking ahead, what do you think has to change for menopause care to become more consistent, more structured, and easier to deliver well at scale?
I think the focus on the revenue generation opportunity is probably the key because clinicians, no matter what, have been trying to solve this problem in one way or another. They have Excel spreadsheets, they have PDFs, they're handing their patients notepads. So it's not convincing them to ask about symptom tracking. We're not changing habits other than making it easier. For it to be accessible at scale, we're gonna have to convince your big kahunas to make sure that they understand the opportunity and why they should prioritize this when things have been going along just fine. That's really, I think, where you see an inflection point, and it's becoming way more mainstream to talk about the opportunity and value in women's health. I think people look at women's health and I don't really know what the like the gut punch is, but that it's frivolous or it's unnecessary, or it's a small market. Like I've had investors say, "Oh, menopause isn't that niche?" And I was like, "You mean the thing that affects all of us, all women, 50% of the
Right.
population? That's niche. Like name another subject matter that is actually that pervasive." Getting through that mental model again, like I mentioned, that the suffering of women is normal as far as, and that there's, if we can get past it and just focus on the money, everyone can talk money no matter what. And I do have to mention in some rooms, I'm like, I can, both can be true. I can love and care for patients and want them to get better, but also want to make a shit ton of money. Like that's both can happen if you do it correctly. And that's what this opportunity uniquely is positioned to do. Menopause is the biggest waste of money from the payer perspective, the most unmanaged cost center. So if you are able to say that to the appropriate people and then just make them talk to a clinician, this is why my sales job has been relatively easy. And so just making sure that we clearly paint the value proposition to each of those core parties is my job. And hopefully what you'll see is why we win.
This has been such a great conversation. Thank you so much for coming on today and sharing your perspective. Before we wrap up, though, can you tell people how they can follow your work, learn more about Amisa? What's the best place to find you?
LinkedIn probably, like, if you're connect with me on LinkedIn, I'm hard to find, I'm a Sam Smith, so good luck. I've been wanting to be stalked for years, has never happened, but if you go to Amisa and then you, follow us, find me, that would be great. Thanks for giving us the opportunity to talk about menopause. I know you woke up today going, "Ooh, you know what I can't wait to do? Talk about menopause."
All right. Thank you so much.